Hello, good evening. This is Occupational Therapist Muneera, and tonight I'm going to speak about occupational therapy while in schizophrenia. Symptoms in schizophrenia varies according to the type of schizophrenia. The first type, which is the psychotic or positive. Psychotic or positive schizophrenia has hallucinations, suspiciousness, and delusion. So the characteristics of psychotic symptoms in schizophrenia are audible thoughts, voices arguing or commenting, thoughts withdrawal, thought broadcasting, impulses, volitional acts or feeling imposed, and delusional perceptions. Secondly, the negative symptoms are impoverished speech, lack of motivation, asociality, and decreased affect. Neurocognitive impairments in schizophrenia are impairments in memory, attention, motor skills, social cognition, executive skills, and disorganized speech. So, why is this important to know when dealing with schizophrenia? In order for us to form the intervention plan, we should know or do a brief assessment about the problems that the patient has. Okay, so what theories or approaches we use when intervening with schizophrenia in mental health setting? In intervention section, I'm going to speak with evidence-based through articles that are searched online and we use in the setting. The main approach we use when dealing with schizophrenic patients is the model of human occupation because of three phenomena. Firstly, model of human occupation is a model that constructs the important concepts of occupation like work, play, or activities of daily living within a temporal, physical, and socio-cultural context that categorize much of human life. So back to why do we use MOHA with schizophrenic clients? Let's see the phenomena. The first concern of MOHA is to understand how persons are motivated toward and choose to do the things that fill their lives. Why is this important? Because if we refresh our memory, in the negative symptoms of schizophrenia, patients have low motivation. And MOHA is client-centered. It focuses on what the client needs and what the client loves. And the negative symptoms also we had. Okay, so what is the second phenomenon? The second phenomenon addressed by MOHA is the recurrent pattern of doing habits that make up every. This is important because in the positive symptoms of schizophrenia with hallucinations and delusions, the roles and routines and habits are affected. So one part of the intervention plan is to give them an activity chart with timing so they can follow to form a routine for them. The third phenomenon addressed by MOHA is that when human beings do things, they exhibit an extraordinary range of capacity for. So MOHA is really important when dealing with schizophrenic patients as an approach that we deal with. In schizophrenia, we also use psychosocial interventions. What are the psychosocial interventions that we use with schizophrenia? As we all know, comprehensive care for schizophrenia involves not only drug treatments, but also the provision of ongoing support and valid information. Psychosocial interventions in schizophrenia are divided into three groups. What are the groups? I'll tell you. Patient education can take a variety of forms depending upon the abilities and interests of the patient. Again, we're client-centered. Educational interventions can be for individuals or a group for the patients, and also an education for the family. Skill training can be through life skills that are intended to promote independent functioning in daily living, or social skills training, which is a long-established psychosocial treatment for schizophrenia, especially with negative symptoms patients. And lastly, vocational skills that focuses on two main programs, which are the pre-vocational training and the supported employment. One of the main problem symptom-focused therapies is the cognitive behavioral therapy that links between the person's feelings and the patterns of thinking, where the participants are encouraged to take an active part by examining the evidence for and against the distressing beliefs, especially with delusions. Secondly, we have cognitive rehabilitation, especially with neurocognitive impairments such as the cognitive or memory impairments. And we have psychodynamic analytic therapy, which is one of the catharsis techniques, and the talking economy. So as seen in the video, sensory integration is not only for children, it's for adults, and we can use it with schizophrenic patients. In catatonic schizophrenia, for example, the patient would stay in one position for a long time, which affects the proprioception. Sometimes with auditory or visual hallucinations, the patient is not exposed to enough auditory or visual stimuli. Also, in negative symptom schizophrenic patients, they have a shoveling gait or psychomotor retardation. What is psychomotor retardation? In psychomotor retardation, the patient walks with their back and neck bent forward and shoulders rotated. So with sensory integration, we can modify their posture and modify their sensory processing skills.